Sir, you are not audible.
Hello, Dr. Mahir. How are you?
How fine, thank you.
Yeah, Vinetosh here.
How are you?
I'm good.
Nice to meet you. Tha- Thank you for the invitation.
So, sorry for little inconvenience. We were running a few minutes late, but we can start your talk. So,
Okay.
for audience benefit, I am just briefly introduce you. Uh, dear delegates and speakers, we are fortunate to have Dr. Mahir Ibrahim Jallo with us. He is practicing endocrinologist and professor with Gulf Medical University, and he is practicing endocrinologist with Tumbe University Hospital, Ajman, UAE. He has a vast experience in internal medicine and diabetes and endocrinology, and he is a very well-known figure in Gulf, and he has done a lot of research in the area of um, diabetes as well as managing diabetes during Ramadan time also, and I am fortunate to got opportunity with publish some posters and paper with Dr. Mahir Jallo. And from my experience, I can say that he is a very prolific speaker as well as he will be very good to listen to your ears actually. So welcome Mahir Jallo sir. Stage is all yours.
Yes. Thank you very much.
And
Thank you,
1 minute,
Professor,
I would like to
for
invite
organizing-
Dr. VP Singh as chairperson for this session also. So Dr. VP Singh is with us. Welcome, Dr. VP Singh. Yes, sir. Mahir Jallo, sir. Stage is yours.
Yes, thank you for the organizing committee for this nice scientific program, and thank you for the invitation to be with you. And I will try for the coming 30 minutes to focus on the comprehensive cardiometabolic disease management, especially in patients with diabetes. So this is the campus of our university, Gulf Medical University and Thombe University Hospital. And this is my disclosure. I work in research in cardiometabolic field with all the cardiometabolic company, but I have no disclosure for this presentation. So just ask yourself, how many of your patients just have type 2 diabetes alone? Usually, this is the data from the chronic disease in the US. 60% of adults in the US has one chronic disease. And more than 40% of adults in the US have more than two chronic disease. And usually, when we speak about the cardiovascular disease, are usually interrelated. For example, the patient with diabetes usually harbor one of the diabetic complication, either the macrovascular or the microvascular. So he may have diabetic retinopathy, neuropathy, CKD, heart disease, and sizable number of those patients also have the liver disease and other disease, comorbidity related to obesity like osteoarthritis. And the importance of focusing on cardiometabolic disease, because it is increased the risk of cardiovascular death. And cardiovascular death is the major cause of death in individual with type 2 diabetes, with patient with NAFLD, now we call MAFLD, and patient with the CKD. Unfortunately, the cardiovascular disease is an inevitable complication in type 2 diabetes. There is a complex and multifactorial pathophysiological pathway in type 2 diabetes which is responsible for cardiovascular disease. Patients with diabetes have higher risk than patients without diabetes to have coronary artery disease, peripheral artery disease, acute myocardial infarction, heart failure, and stroke. And we know that usually the atherosclerotic cardiovascular disease usually increase with the presence of many modifiable and non-modifiable risk factor. We can do nothing about the previous history of cardiovascular event, the age of the patient, the race, the sex, and the genetic as non-modifiable. But there is sizable for the modifiable risk factor. which include the dyslipidemia on the top, hypertension, the sedentary lifestyle, smoking, and also managing properly type 2 diabetes and even the metabolic syndrome. Of course, not forget obesity and the role of inflammation. And despite
Dr. Mahir,
receiving
are you sharing the slide also?
yes, it is not there.
No, it's not moving actually.
How?
Please keep it in presentation mode. Let's check.
Only first slide.
Only we are seeing the title slide visible.
Only? Oh, okay.
Yeah.
Let me go and again. 1 minute.
Yes. F5.
Screen sharing has stopped as the shared window is closed. Why? Okay. We will make it again.
Yeah.
Share. Okay, so where is
Press the escape button.
1 minute.
He's not able to present. Yeah. Yeah. So it's visible there, little green button with arrow.
Now?
Yeah. Now keep it in presentation mode. Yep. Now change the
Yes.
slide. Try to change the slide.
Now?
Yes. It's working.
Oh,
Thanks.
okay. So we'll start from the beginning. Yes. So this is my disclosure. I have no disclosure for this presentation. So just ask yourself, how many of your patients have just type 2 diabetes? This is a statistic from chronic disease in the US. 60% of adults in the US have one chronic disease. More than 40% in the US have more than two chronic disease. And we know the cardio-metabolic disease are interrelated. Patients with diabetes usually have one of the diabetic complications, micro or macrovascular. He may have liver disease and also other comorbidity related to obesity. And the importance of focusing on cardiometabolic disease that it is the risk factor for cardiovascular death. Cardiovascular disease is the major cause of death for individual with type 2 diabetes, NAFLD, which is now we call muffled, and the CKD. And usually cardiovascular disease has inevitable complication of patients with type 2 diabetes. Complex and multifactorial pathophysiological pathway are responsible for cardiovascular disease. Usually patients with diabetes have higher risk of coronary artery disease, peripheral vascular disease, acute myocardial infarction, heart failure, and stroke than peers without diabetes. And we know that in the atherosclerotic cardiovascular disease, there is some unmodifiable risk factor that we can't do anything, but we have scope to tackle the modifiable risk factor, which is lead to increased cardiovascular disease, coming on the top, dyslipidemia, the hypertension, the type 2 diabetes, and other sedentary lifestyle, smoking, and obesity. And despite receiving cardiovascular disease standard of care, still patients with type 2 diabetes and established cardiovascular disease at risk and need additional cardio protection. We know that we manage the cardiovascular risk management with the statin for the lipid, with the RAS blockade for blood pressure control, with the antiplatelet, antithrombotic agent, and also we tackle the glucose control through various available medication. And even if we drop the HbA1c below 7, but still patient with type 2 diabetes at nearly double or 1.7, almost double the risk of cardiovascular death compared with the general population. So we need to multifactorial approach. not focus on the glucose alone, blood pressure important, lipid important, as well as, glucose important, because all these may be impacted in reducing the MACE. And in some stage, probably addressing the dyslipidemia, probably more important than addressing the sugar in patient with diabetes. We know that there is a close link among the CKD, diabetes, and heart disease. And the presence of diabetes with the CKD increase the risk of death from cardiovascular disease. And usually our patients of the CKD die from cardiovascular disease rather than from his dialysis. And the CKD is common in patients with diabetes. Approximately 1 in 3 adults with diabetes have CKD, as well as heart disease is so common in patients with diabetes. People with diabetes are 2 times more likely than others to develop cardiovascular disease. And we publish our study about the prevalence of cardiovascular and renal comorbidity in patients with type 2 diabetes in the Gulf. This is a cross-sectional observational study which is published in the Diabetes Therapeutic recently, and we have 44% of our patients with diabetes, both in the tertiary and the primary care center, have stage 2 or 3 CKD. 15% have cardiovascular disease, and in decreasing prevalence, other cardiovascular events. What is the risk factor for cardiometabolic? We know that the traditional, the hypertension, high triglyceride, obesity, lifestyle, smoking, and alcohol, which is need to be assessed as a risk factor during each visit with the patient. And there is some modifiable risk factor. There is a scope to work on it. The weight, the alcohol habit, the smoking, the exercise, the diet. And usually we need to evaluate what we can do and what we can change in the patient lifestyle to modify this risk factor, because we can't do anything among the non-modifiable risk factor. And I think our visit, the clinician should review the patient chart if there is this, the time constraint. I know it is a very big issue in our clinical practice, but clinicians, especially in the specialized center, should review the patient chart before the visit. When was the last HbA1c? When the last, microalbuminuria? What is the GFR of the patient? And we can take this opportunity, especially in the primary care center, to assess for other, screening program. When the mammogram done for this lady, when the prostate-specific antigen checked for this man, and also when the colonoscopy advice and screen done, and also woman exam. This is a comprehensive approach to a patient care. And usually we should think what laboratory value were abnormal the last visit. So what was the new medication or therapy added? And because we need to assess the impact. And what issue did the patient have in the last visit to see the assess. So close clinician-patient relationship is very important in preparing for the patient visit. I will focus on the chronic kidney disease and type 2 diabetes, because now we have many medication which can impact the renal parameters and decreasing the risk of future cardiovascular disease. Now, urine albumin to creatinine ratio is very important, and this should be done at least once annually or every 6 months to check for the protein in the urine, which is one of the earliest indicator of the CKD or kidney damage. And usually we need to measure also the GFR of the patient. Why it is important? Because in the new guidelines classification of the scheme we are not only focusing on the degree of the GFR, but also on the degree of microalbuminuria. And with the increasing degree of microalbuminuria, it transmit the patient from low risk to moderate and high risk. And this will guide us when we can refer our patient to the specialty care. So both those parameters are very important to be screened periodically. And as we mentioned, annually thereafter, if we start, and sometimes we need to do it twice to confirm the presence because, sometimes if the patient have urinary tract infection, you may get positive, microalbuminuria, which is probably not there if you recheck after 1 month. Another focus is the heart failure, which is very important comorbidity in patients with type 2 diabetes. Usually the patient may present just with fatigability, some shortness of breath. So probably the simplest thing we can do is an order the NT-proBNP as a screening because this is very sensitive in the presence of initial heart failure. We may also listen to the lung to see if there is any crackle and perform the bedside echocardiography if this facility is available. And usually the American Heart Association cardiology guidelines that, at risk of heart failure, that those patients at high risk of heart failure, but without structural heart disease or symptoms of heart failure. The stage B, structural heart disease, but without sign or symptoms of heart failure. And we have the heart failure with symptoms, stage C, structural heart disease with a prior or current symptoms of heart failure, and the stage D is refractory heart failure. NAFLD is another very important association of cardiometabolic comorbidity, and with this, we have simple tool which can be detected in the primary care, ultrasound, if there is possibility for the transient elastography, the FibroScan give a good idea, and especially with the promising new medication may be coming recently for the management, measure the liver stiffness, and also you can use the fibrosis 4, this is scoring for the age, liver enzymes, and the platelet count. Non-invasive tests improve the detection of advanced fibrosis while reducing the unnecessarily referral in patient with NAFLD. Unfortunately, currently there is no FDA-approved treatment till recently last month, and the management should promote various cardiometabolic health, and the study are investigating the role of the GLP-1 receptor agonist in patients with NAFLD. Do I need to refer my patient with the CKD to specialized care? First of all, we need to concentrate on the healthy diet, smoking cessation, importance of physical activity, the weight management, and the regular risk factor assessment every 3 to 6 months. And in some stage, if we see decline in the GFR, and increasing microalbuminuria, difficult to control hypertension, or glycemia, this is the stage to refer to specialized care. Of course, we should utilize now the well-known first-line drug therapy for patients with the CKD, SGLT2 coming on the top, if the GFR more than 20, and continue until the stage of dialysis or transplant. Of course, metformin can be another medication to control if the GFR above 30, and don't forget the RAS inhibitor at maximum tolerated dose if the patient have hypertension or microalbuminuria. We know the SGLT2 have, been found to decrease the cardiovascular risk and CKD, and think of the possibility of the genital mycotic infection as one of the side effects of this medication, and the initial decrease in the GFR. Don't afraid of this, because in the long term, it will be corrected, and the long-term data show us that the SGLT2 will improve in the GFR. So initial dip is part of the mechanism of the SGLT2 inhibitors. Healthy heart, healthy diet is very important. I think we know all the tips for that, to decreasing the saturated fat, and also to calorie restriction to manage overweight and obesity. What is the medical management of heart failure? We have now well-known 4 pillars: the beta blockers, the ARNI, ACE or IRB, the SGLT2 become essential part of the management of patients with heart failure, and in some stage we need to add the mineralocorticoid receptor antagonist. We should start as early as possible. All the medication in decreasing dose, and then increase the dose according to the patient tolerability to make the patient utilize the most benefit of all the evidence-based molecule which is incorporated in the management of heart failure. And heart failure screening is easy. Ask the patient about shortness of breath, check for edema, listen to the lung, brain natriuretic peptide, which is screening, can be done, and echocardiogram. Unfortunately, 30% of the time, the primary care missed the early heart failure. What about dyslipidemia? Usually, most of our patients are a high or very high risk for cardiovascular disease, and usually we need to utilize the high-intensity statin with a dual therapy with ezetimibe. Of course, if it does not achieve the target, the PCSK9 inhibitor should be added, and also we should think of prescribing the strength omega-3 fatty acid medication if we achieve the target of LDL, but the triglyceride is still high, above 150. Now, there is a huge focus on the weight, and most of our patients are overweight or obese. And now the rule of the GLP-1 therapy have, fundamental impact on weight and become part of the initial management in patients with established atherosclerotic cardiovascular disease or patient with obesity. In addition to the weight impact, they have many pleiotropic effects, and we know that the GLP-1 have increased cardioprotection, decreased coagulation, and also decrease the postprandial lipid, will have an impact in controlling glucose without it producing hypoglycemia, decreasing inflammation, the body weight, the blood pressure, and also some natriuresis or diuresis. And we can see this group of medication will have impact in many aspects of the cardiometabolic, in obesity, in diabetes, in the cardiovascular disease, in patients with NASH, and patients with the kidney disease. So now to focus, to put all these approach in a journey of Mr. Ahmed, who is one of our patients, and how we apply these evidence-based data in his management. Ahmed is 56 years old, known with type 2 diabetes for 10 years duration, with hypertension, dyslipidemia. He is a smoker, 1 pack per day, and married and has 4 children, work as manager of a small private company, and his work is sedentary and stressful. His data that the body mass index is 30.1, blood pressure 145/82, with bilateral background diabetic retinopathy and bilateral pins and needle with mild pain on his feet, that the features of neuropathy. His lab finding, the HbA1c is 8, average fasting is 80, but the problem with the postprandial 220, total cholesterol 245, the LDL is 96, the HDL 34, and the triglyceride 225. The calculated GFR is 76, creatinine 101 micromole, and the microalbuminuria is 20, so it's not had no microalbuminuria. ALT 35, AST slightly high 44, and the TSH is 2.4. So now his current medication is the dapagliflozin and metformin in the maximum tolerated dose, which is 10 milligram DAPA and 2 gram of metformin. He's taking glargine, insulin, U100, 82 units at the bedtime, rosuvastatin 10 milligram once daily for dyslipidemia, and lisinopril 20 milligram once daily for the hypertension. This is his CGM, which is done, and you can see the clear dip of hypoglycemia with his U100. And fasting, which is controlled, but the problem with postprandial. What is your management priority for Ahmed? Of course, we need to tackle his diabetes, and we tackle his dyslipidemia. Despite his LDL still 96, he is in the category of high-risk group. So we need to improve his HbA1c without hypoglycemia and reducing the nocturnal hypoglycemia risk, And for dyslipidemia, we should work to reduce further his LDL with his current medication. So how we can approach his diabetes? Now, easily, probably we can, without adding more injection or other medication, we can switch his glargine U100 to U300 with the same dose at the bedtime. What is the difference between, the 100 and U100? We should also think of the ideal characteristic and the potential clinical benefit. The duration of action is longer, more than 24 hours. So this will give us the chance to give it as once daily injection, and also flexible injection timing, which is not there with the U100. Flat pharmacokinetics and dynamics profile, and this is also to produce low risk of hypoglycemia and flexible injection timing, and low variability in insulin exposure and action, which is facilitate the insulin titration with lower risk of hypoglycemia. And this is the difference between the U100 and U300, less glycemic variability and reduce the risk of hypoglycemia. This is the U300 care, and this is the 100 care, and you can see the difference in the fluctuation. So just simple changing the basal insulin for Ahmed will help him to avoid hypoglycemia and achieving better 24-hour coverage and better glycemic control. And this is the data that consistently effective glycemic control comparing to 100 to 300 in various edition trial which is done, but this is translated the same HbA1c reduction, but decrease incidence of hypoglycemia at any time, and specifically the nocturnal hypoglycemia. So next visit after 3 months for Ahmed, after shifting, he is still on the medication DAPA, now on glargine U300 with slightly up titrated to achieve the target because his HbA1c is still higher. And this is the initial first CGM for him, and this is now the CGM without any evidence of hypoglycemia. I mean, not less variability in the 24-hour blood glucose measurement. So now his HbA1c dropped to 7.2, the average fasting 100, and the postprandial reaching 180, which is much better than the previous reading of above 200. Now his current medication, the DAPA the same, the glargine U300, the rosuvastatin 10, and lisinopril increasing to 20 milligram to achieve a blood pressure target. And now we need to think about, is this LDL is enough? What we do, just we need to double the dose of Rosuva or think of another approach. We know that the lipid-lowering therapy accounted for the majority of the risk reduction in patients with diabetes, more than the HbA1c and more than the systolic blood pressure. So the lipid at some stage become more important than glycemia. And we can see that the lower the LDL, the less incidence of cardiovascular range, about, a sequences of range of LDL lowering. The majority of our patients are high risk or very high risk, and we aim for LDL below 70 or very high risk below 55. So should I double the statin dose or combine? Any doubling will just produce 6% further reduction. Usually we need to think of combining the therapy. So in our patient with high or very high risk, we aim for a blood LDL below 70 and 25, and usually doubling the dose will not able to achieve. For his 96 LDL, 6% will not achieve the 70 LDL lowering. So with this patient, that we should think about the expected clinical benefit when we prescribe the lipid-lowering therapy. The moderate intensity statin will produce 30% reduction, high-intensity statin 50% reduction, combination with ezetimibe 65, and the adding PCSK9 60%, PCSK9 plus high-intensity statin, 75%, and the 3, 85%. And we need to calculate these to achieve the target LDL for our patient. How I can achieve the target below 70 for Ahmed? Instead of doubling the dose of rosuvastatin, I combine rosuvastatin with ezetimibe 10 milligram, and this is coming in the guidelines since 2019 that if the patient not achieve the target, the combination should be there. Unfortunately, this is international analysis of 17 guidelines and 42 observational study, up to 70-80% of the patient not achieving the target below 70 despite they are high-risk cardiovascular disease. And probably this is part of our inertia. And the ACT study show exactly that doubling the dose of rosuvastatin is inferior to adding ezetimibe for further reduction, and usually this is translated in up to 70% reduction in the LDL target. You can see the combination therapy is superior to doubling the dose of rosuvastatin. The next visit in 3 months is now total cholesterol 135. The LDL is achieved 68. HDL acceptable, should be above 40, and the triglyceride 198. Now the rule of primary care is very important. Most of those patients never seen in the tertiary care, diabetic center, or in the consultant. So the rule of primary care is very important because he is in the center between the endocrinologist, cardiologist, dietitian, pharmacist, nephrologist, and the gastroenterologist, hepatologist, if the patient harboring the NASH. And with this patient-centered care is very important to achieve our target. Always, you should have system in place to screen, diagnose, manage, monitor, and follow up. Just refill the prescription is not an optimal approach. And the newer medication are indicated for cardiovascular risk management. Please make use, as I know it is not possible every time, but whenever you get the chance to be prescribed, it translates, the level from glycemic control to kidney protection and cardiovascular protection. Usually treating cardiometabolic disease with, have an impact on secondary cardiovascular risk reduction, have the evidence and guidelines-based process, and usually improve the quality of life, and usually this is have an impact on patient-centered collaborative care. The SGLT2 play a role not only as patient medication for diabetes, but for the CKD and heart failure, and decreasing the risk of cardiovascular death. GLP-1 therapy have the risk to impact the MACE as well as impact the weight, which is very important comorbidity in patients with diabetes, and usually combination of both usually incorporated in the etiology. And now they are not only in the guidelines of diabetes, they are in the guidelines of the cardiology as well as in the guidelines of nephrology. So the need for cardiologists to impress, this is very nice slide. Cardiologists have 4 times as many inpatient encounter with people with type 2 and cardiovascular disease than endocrinologists. We don't admit too much patient of diabetes because of diabetes control, but the cardiologists admit for the cardiovascular event. Yet, fewer than 7% of people with type 2 diabetes and atherosclerotic cardiovascular disease are on optimal medical therapy, including the GLP-1 and the SGLT2. So we need an effective clinical care model to preventive cardiology in collaboration with endocrinology and the primary care. For the key support staff and personnel, extensive treatment plan, patient experience and outcome, and comprehensive coordinated care. And in some center now, there is Cardio-Metabolic Center Alliance or huge Cardio-Metabolic Clinic when the diabetologists, cardiologists, nephrologists sitting together to decide the patient center model And will have an impact, significant reduction in the HbA1c, body weight, systolic blood pressure, lipid, and daily insulin dose versus control. More than 18 fold higher use of the optimal medical therapy versus control, nearly 100% use of GLP-1 or SGLT2, and reduction in the key cardiovascular risk factor out of 2. So if these centers become available in the future with national network of cardio-metabolic clinical support and the practice management and implementation, usually the clinical and patient education resources will become, much enhanced, and definitely this is translated in a future reduction of cardiovascular disease. So my dear colleagues, my take-home message: type 2 diabetes is a progressive disease often requiring combination therapy. Type 2 diabetes is just a facet of cardiometabolic risk associated with obesity, dyslipidemia, and hypertension. Delayed treatment intensification contribute to suboptimal management of hyperglycemia in patients with type 2 diabetes. The guidelines recommend addition of combination therapy for type 2 diabetes not achieving the glycemic target. Basal insulin has an important role in the treatment of patients with diabetes, but the new generation should be always considered for the 24-hour cover and less risk of hypo. Glargine U300 is as effective as Glargine 100, but with less hypoglycemia. LDL lowering is always beneficial, and high-intensity statin are the first line, but combination with ezetimibe or PCSK9 is the next step if target not achieved, and more effective than doubling the dose of statin alone. Thank you very much, and I am ready to take any of your questions.
Thank you, Dr. Jallo, for your such an insightful session. Now I will pass the mic to our chairperson, Dr. VP Singh, for further comment. And
thank you, Dr. Mahir, for vast coverage of the metabolic disease, and it covers the whole of the metabolic complications, diabetes, hypertension, and how we can control diabetes will lead to the further decreased complication of the cardiovascular disease and all that. And you're more focused on the SGLT2 inhibitors and others lipid lowering problems is the further reduction for the cardiovascular disease. Thank you for the vast coverage. We are highly obliged.
Yes,
thank you, Dr. VP Singh.
The audience will have, detailed from the speaker of other, other speaker will cover the